The Templetons were making plans for their newest edition, but Boss Baby has other plans. Wearing his business suit and holding his briefcase, Boss Baby is about to uncover the biggest crisis of a 9-month-old baby girl who experiences an imbalance in her once healthy life. Ladies and gentlemen, beloved teachers, Dr. Monsanto and Dr. Kapungkol, and fellow first-year medical students, welcome to Biochemistry's Group 6 case presentation. I am Geraldine Calvero, your MC for today. Our presentation of the case will be sequenced as follows. The history and physical examination of the patient will be presented by yours truly. Then it will be followed by the presentation of our differential diagnosis and final impression by Ms. Alifosa. And together with Mr. Ormaneta, they will be explaining the pathophysiology and management of the disease. Without further ado, let me present to you the history and physical examination of the patient. In the baby corporation, life was perfect until one fateful day. A sudden disease attacked. The boss baby, only he could unravel and find a cure to the ruthless disease. The patient is a 9-month-old girl, the second child of unrelated parents. She was admitted to the emergency department in a coma and suffering for the last 12 hours. She was with a slight fever. Her mother also reported that while she liked cheese, meat, and fish, she frequently became irritable and greasy after meals and became lethargic, drowsy, and floppy after eating relatively large amounts of protein-rich foods. Her urine also had a curious odor, described by her mother as being cat-like on such occasions. For her physical examination findings, the patient's muscle tone was poor and she was very weak with considerably less strength than would be expected for a girl of her age. For the anthropometric measurements, the patient weighed 8.8 kilograms at the time of admission, and her body length was 70.5 centimeters. She has a normal height and weight for age measurement. For the laboratory examination, a blood sample was taken for full clinical chemistry test, and she was given intravenous glucose. Within a short time, she recovered consciousness. The results of the blood test showed that the patient's glucose, pH, and bicarbonate levels are all below normal, while both her levels of ammonium and non-esterified fatty acids are above normal. Ketone bodies, on the other hand, are undetected. Lastly, the patient's insulin and glucagon levels are both normal. She was generally well through this time, but became drowsy and severely hypoglycemic and hyperventilated if she was deprived of food for more than about 8 to 9 hours. On one occasion, her blood glucose was monitored at 30-minute intervals over 3 hours from waking without being fed. It fell from 3.4 millimoles per liter on waking to 1.3 millimoles per liter 3 hours later. She was deprived of breakfast again the next day, and again, blood glucose was measured at 30-minute intervals for 3 hours, during which she received an intravenous infusion of beta-hydroxybutyrate in 50 micromole per minute per kilogram body weight. During the infusion of beta-hydroxybutyrate, her plasma glucose remained between 3.3 and 3.5 millimoles per liter. At no time were ketone bodies detected in her urine, and there was no evidence of any abnormal expression of amino acids. However, a number of abnormal organic of 3-hydroxy-3-methylbutyric and 3-hydroxy-3-methylglutaconic acids. The expression of these two acids increased considerably under two conditions. First is when she was fed a relatively high-protein meal. She became grizzly, lethargic, and irritable. A blood sample taken after such a meal showed significant hyperammonemia of 130 micromoles per liter, but normal glucose of 5.5 millimoles per liter. And second is when she was fasted for more than the normal overnight fast, with or without the infusion of beta-hydroxybutyrate. One obvious metabolic precursor of 3-hydroxy-3-methylbutyric acid is 3-hydroxy-3-methylbutyryl-CoA, which is normally cleaved to yield acetoacetate and acetyl-CoA by the enzyme hydroxymethylbutyryl-CoA lyase. Therefore, the activity of this enzyme was determined in leukocytes from blood samples from the patient and her parents, wherein all showed results that are below normal than the control subjects. Analysis of the patient's urine also revealed considerable expression of carnitine. Her level of free carnitine is normal, however, both her total and acyl carnitine levels are above normal. With the history and physical examination presentation, I know that you already have a diagnosis in mind. To give you our group's insight, let us listen to Ms. Alifosa.
Initial findings with our patient show irritability and lethargy after eating a protein-rich meal, cat-like odor of urine, convulsions, refusing all food and drink, and weight loss. We ruled in metabolic disorder and infection, trauma, or CNS anomalies, but since there were no apparent signs of infection, trauma, or CNS anomalies, we ruled them out. Next, since the patient has hyperammonemia, we considered urea cycle defects and organic acidemia. However, urea cycle defects usually present with respiratory alkalosis. So we also ruled it out because the patient has metabolic acidosis. We are then left to determine what form of organic acidemia the patient has. Since the patient showed no signs of ketosis, we also ruled out excessive ketone body producing diseases, such as methylmalonic acidemia, propionic acidemia, ketothiolase deficiency, maple urine syrup disease, isovaleric acidemia, and multiple carboxylase deficiency. Finally, we looked at the characteristic metabolites that the patient excreted. But both acyl-CoA dehydrogenase deficiency and HMG-CoA synthetase deficiency are not characterized by the presence of hydroxymethylglutaric acid and hydroxymethylglutaconic acid in the urine. So we ruled them out and made our final diagnosis of HMG-CoA lyase deficiency. HMG-CoA lyase activity test performed on the patient showed very low enzyme levels, which indeed confirms the diagnosis we have made.
Thank you, Ms. Alicosa. To delve deeper, Mr. Ormanata will now proceed to discuss the mechanism of the disease.
Boss Baby has traveled wide in search of answers. At this point, he has come to the near conclusion of his journey of searching for the diagnosis. The final diagnosis has already been presented. Let us now learn the mechanism by which this disease wreaks havoc on what. Sorry. Sige, makakat maninig ako ng bahala. Boss Baby has traveled wide in search of answers. At this point, he has come to the near conclusion of his journey of search for the diagnosis. The final diagnosis has already been presented. Let us now learn the mechanism by which this disease wreaks havoc on what was once a harmonious system. HMG-CoA lyase is an enzyme that converts hydroxymethylglutaryl-CoA into acetoacetate and acetyl-CoA. The enzyme is required for both ketogenesis and leucine catabolism, therefore resulting in ketone bodies, which are essential fuels during fasting and starvation. In HMG-CoA lyase deficiency, which is a metabolic disorder caused by a mutation in the HMG-CL gene, the body is deemed incapable of synthesizing ketone bodies. As a result, abnormal metabolites accumulate and are excreted in the urine. In individuals with this disease, symptoms are usually not manifested during fed state, but when the body is deprived of glucose, such as in fasting, metabolic decompensation are exhibited by the body. This metabolic crisis is initiated by the accumulation of hydroxymethylglutaconic acid and hydroxymethylglutaric acids, and the subsequent effects are described as follows. First, the accumulation of acid metabolites from leucine catabolism causes metabolic acidosis and aciduria. These acids, namely hydroxyisovaleric acid, methylglutaconic acid, methylglutaric acid, and hydroxymethylglutaric acid, are normally buffered by bicarbonates. However, excessive metabolites production depletes the alkali stores, resulting in acidosis. The primary metabolic acidosis initiated by the abnormal acids stimulate the peripheral chemoreceptor to decrease the bicarbonates by causing hyperventilation. Third, carnitine is required for the transport of acyl-CoA into the mitochondria for beta oxidation and the capture of hazardous metabolites for excretion. Carnitine combines with the aberrant metabolites in HL deficiency to help them pass through the urine, resulting in its esterification to methylbutyryl carnitine. As a result, the carnitine reserves are depleted, leading to secondary carnitine deficiency. Fourth, the presence of carnitine is required for beta oxidation of fatty acids. Unfortunately, the pathway's function is also hampered by the depletion of the molecules. This further restricts the body's energy sources, which has been initially limited due to lack of ketogenesis. Fifth, when all the fuel sources are depleted, the body turns to protein catabolism to provide glucogenesis substrates and metabolic fuels for all tissues. Increased transaminases are employed for oxidative deamination in the degradation of proteins. This raises ammonia release, which must be converted to urea before being excreted. Next, The abnormal metabolites compete with acetyl-CoA to form N-acetylglutamate, which is an allosteric cofactor for carbonyl phosphate synthase 1. As a consequence, a secondary impairment of the urea cycle occurs, which results in hyperammonemia. Next, we will be discussing the extent of the various metabolic problems we have identified based on the information given to us, which includes the following: irritability, lethargy, and drowsiness after taking large amount of protein-rich foods, cat-like odor urine, coma and convulsions, refusal of all food and drink, acidosis, hypoglycemia, negative ketone bodies, hyperventilation, weakness and poor muscle tone, increase in glucose after administration of beta-hydroxybutyrate, and lastly, urinary excretion of carnitine. Irritability, lethargy, and drowsiness after taking large amount of protein-rich foods. Protein-rich foods normally induces metabolism, releasing peptides amino acids such as lysine. Since the patient lack the enzyme HMG-CoA to degrade lysine, abnormal metabolites accumulate in the body after a protein-rich meal. Consequently, these organic acids compete with acetyl-CoA, inhibiting the formation of N-acetylglutamate for the activation of the urea cycle. Thus, the ammonia released for the protein catabolism are not converted into urea for excretion. Instead, they accumulate in the body and affect the nervous system, manifesting into neurologic disorders such as irritability and grisly behavior. Hyperammonemia is also the cause of poor feeding and lethargy in this patient. Next is cat-like odor of urine. The presence of abnormal acid in urine of the patient caused a remarkable cat-like odor, coma, and convulsions. As I described earlier, consumption of high-protein diet results in an increase in blood ammonia. Ammonia, when not converted to urea, affects the brain by its reaction with alpha-ketoglutarate to form glutamate. Therefore, the store of alpha-ketoglutarate for the citric acid cycle are depleted, resulting in decreased production of ATP and reducing equivalence. Since the brain requires high amount of ATP and it's dependent on citric acid cycle for energy formation, this reduces brain function, resulting in convulsion and even coma. Next is refusal of all food and drinks. Because of hyperammonemia, the patient body is reacting by avoiding all food and drink. This avoidance behavior prevents her from consuming meals or beverages that could further increase ammonia formation. Next is acidosis. The formation of abnormal acid after fasting or high protein meals causes the patient's acidosis. When these acids are continuously produced, they depleted the body alkali reserves, leading to metabolic acidosis. Hypoglycemia. The hypoglycemia experienced by the patient is more than just a result of her fasting, but is also a complication of her metabolic crisis. When the blood glucose supply is decreased during fasting, hypoglycemia triggers the release of glucagon and the creation of ketone bodies. Ketone bodies keep glucose from becoming depleted, ensuring a steady supply of glucose-dependent organs and tissues. But when ketone bodies aren't present, just like in this patient, this protective mechanism is turned off, and glucose reserves are drained completely. To complicate things during metabolic crisis, the body is unable to utilize fatty acid for energy due to, due to shortage of carnitine, even when there are sufficient supplies. This leads to body's total reliance on glucose, which results in severe hypoglycemia. Negative ketone bodies. The patient is unable to manufacture ketone bodies because she lacks HMG-CoA in her body. Hyperventilation. Because of the patient is experiencing metabolic acidosis, the body responds by causing hyperventilation, which is initiated by stimulation of peripheral chemoreceptors. The process results in increased exhalation of carbon dioxide to return the blood pH back to normal. Weakness and poor muscle tone. The muscle wasting and weakness exhibited by the patient is caused by the excessive protein catabolism during metabolic crisis. This all begins when the glucose reserves have been totally depleted and the beta oxidation pathway has been impaired by exhaustion of carnitine. This consequently forces the body to obtain energy from protein, which must be catabolized, releasing amino acids and decreasing the protein mass of the body. Next, increase in glucose after administration of beta-hydroxybutyrate. As previously mentioned, ketone bodies have the ability to spare glucose. So when the beta-hydroxybutyrate has been administered to the patient, most cells shift from glucose as main fuel source to ketone bodies. This therefore is seen as an increase of glucose levels in the blood. Lastly, urinary excretion of carnitine. Carnitine helps to capture harmful compounds produced during metabolic crisis. It is then esterified to methylbutyl-carnitine during the process, which is excreted in the urine. The presence of elevated acetylcarnitine levels in the patient's urine indicate organic acidemia. In this case, it is HMG-CoA deficiency.
Wow, now that's convincing. Thank you, Mr. Ormaneta. We are almost nearing the end. To give us an idea about the treatment recommendations for HMJ-CoA lyase deficiency, may we call on Ms. Aliposa.
Prompt treatment is needed if the child has HMG lyase deficiency to prevent metabolic crisis. Usually, treatments are needed throughout life. Avoiding fasting is one dietary adjustment that can be done to keep the child in good health. This is critical to avoid hypoglycemia, which usually results in the metabolic crisis. Another recommendation is to adopt a low leucine diet, medical foods, and formula, as well as high carbohydrate, low protein, and low fat diet. The low leucine diet will prevent the catabolic pathways for leucine that rely on the absent enzyme. The high carbohydrate diet, on the other hand, will prevent onset of hypoglycemia. However, because proteins and fats are still required for a child's growth and development, it is not advisable to exclude them entirely from the diet. Additionally, several medications may aid in the prevention of the metabolic crisis. Carnitine is one of those, and it has been proven to aid some children with that condition. Finally, during a metabolic crisis, the child should be taken to the hospital immediately for a treatment and care to ensure recovery and survival. There, she will be given glucose, bicarbonate, and other medications by IV. With the boss baby's help, life in Baby Corp went back to normal, and a new era of peace and harmony began. All hail the boss baby and the baby associates.
On behalf of Group 6, we would like to extend our heartfelt gratitude for your attention and attentiveness. We hope that you have learned a lot from the case presentation. May God guide us every day and grant us the knowledge and power to help others. Go for it, future doctors. Fight and never give up.